third episode of the third season. And this is brought to you by IBIA and NABIS. And I want to thank the IBIA crew for helping with background technology. It's always fun to have a bunch of people backing you up. So welcome to the episode. And you can find the first season, second season, the last two episodes up on YouTube under the Pink Concussions channel. So I'd like to welcome Dr. Wexler. How are you doing today?
I'm great. I'm delighted to be here. And it's so nice to see some faces also while we're speaking. It's been a little isolated these last months. So it's great to see faces while we're talking.
We have a very active crew here at Casual Conversations. So I'll hold them at bay a little bit, hold the questions at bay for a little bit and just get to talk to you for a little bit before we go to sort of a Q&A mode. So I wanted to ask you, when did you decide you wanted to be a doctor?
A little bit later than maybe some of my colleagues or friends in medicine. I had thought I always wanted to teach. I wanted to be a professor. It's kind of the family business is being a professor of something, but I really wasn't sure of what. And when I was applying to graduate school, I talked to someone whose work I really admired, and he's like, you're so interested in health, you should think about doing an MD PhD program. And I was like, well, I've always loved health and like working with people. And so I kind of fell into medical school, and it was such a great fit. I think it's such an honor to get to hear people's stories and have them choose to share with you. So I really was lucky to kind of find the right thing that way.
And when you started school, did you have any idea what you wanted to specialize in?
No, you're given the choice to kind of do what are called sub-internships. So you get to try being an intern really in different areas. And I may have at least tied for the lead at doing it in 4 different areas in neurology, psych, peds, and internal medicine. But I'd always really loved endocrinology and neuroendocrinology, and ended up doing both my research, the PhD research, in something similar to that area, and then went on to do internal medicine in order to do endocrine. So looking back, it seems like should have been an easy choice, but it took a little bit of time to come to also.
And what excited you about this part of the body? What drew you in?
In our first year medical school class, we had this wonderful professor. His name is Francis Sterling. He was Francis Sterling in Philadelphia. And I remember his excitement at describing the feedback loops that are really important in pituitary medicine and neuroendocrinology, where the body kind of keeps itself in equilibrium. He was a wonderful guy, a wonderful teacher. He used to go see patients, even though he'd retired, like for free, just would go see patients. And I'd go over with him sometimes. And so that really is what got me interested in it. And that interest never waned. I mean, I still, my poor patients leave the office with like sketches of the feedback loops more often than they'd like, I'm sure.
And did at that point, did women's health interest you, or it was a general piece of it? When did the sort of the sex differences come out for you?
That was part of it. So the endocrinology for me includes sex hormones and estrogen and women's health and reproduction. So certainly from an academic standpoint, for me, it falls into it. And I was actually really lucky in that perhaps unique or among some of the fellowship programs, the place I did my fellowship in endocrinology, reproductive endocrinology, which has a lot of the women's health aspects, although certainly not all of them, was part of endocrinology. So usually it's an OBGYN program, but where I trained, it was within endocrine. So I was able to do training in that as well, and have really always done both reproductive endocrinology for men and for women. And that really helps highlight some of the differences actually in neuroendocrinology.
And then when did that segue into the brain injury piece?
That didn't happen until around 2015. I was then at NYU, and someone sent over a patient from the Concussion Center who'd had a concussion and who was describing issues they thought might be related to some hormone changes. And it sort of had this flashback to, I should explain, I've seen patients with problems with different pituitary hormones at that point for, over a decade. And that includes sex hormones, growth hormones, thyroid hormone, and stress hormone. And I remember this list of these sort of allowable potential causes of growth hormone deficiency. And we really focused where I did my training on tumors, radiation, surgery, things like that. But top of that list was always traumatic brain injury. And I really hadn't thought about it much, but that kind of flashed back into my mind, and I started looking into it. And it was certainly well described. There just didn't seem to be a lot of awareness about it. I got really interested in that because not only one of the things I'd always hoped to do was to be able to help a large group of people, right? And the research I was doing was really for sort of much more rare diseases. You know, concussions affect a lot of people. So if there's something you can do research into or help raise awareness of that would help more people, that really dovetailed with my public health interest also.
And at that point, you're coming to brain injury with the sex differences already baked into what you're doing. So you're approaching, I think, in a very different way than other specialties where, you know, sort of we have to pry away the differences. So you were looking at it as you walked into it with the chemical differences between males and females, right?
Yes, absolutely. With the hormonal differences, the different ways of looking at things. Already, unfortunately, an awareness of the fact that sometimes concerns in women may be considered to be stress or something else instead of a hormonal change or a physical change. And so that was something I was already familiar with when I came back to the brain injury field. My graduate work was in neuroscience, so there was certainly some work in terms of neuronal damage, but really I was looking at this now from a hormonal point of view. I feel like that distills it down too much. Kind of more holistic thing, like how are people affected? How does that affect their hormones? How does their effects of their hormones change how they feel and experience things? It touched a lot of the things I really wanted to work in.
And I think also with brain injury, so many of those areas are affected, and to try to figure out the source. And the thing that excites me about the hormonal aspect is that, you know, it's a directly treatable part of brain injury. So I think that's what excites me about, you know, opening people's eyes to that possibility.
I will admit that there is a piece of my interest in endocrinology that had to do with that. I considered approaching this from the neurology side, and there are many neurological illnesses where at that time, at least, it felt like there wasn't as much you could do. You can always make something less bad, but you couldn't cure everything. For pituitary hormone deficiencies, replacing the deficiency should reverse whatever is a symptom of that deficiency. And so the thought that by finding something, by kind of raising awareness, you know, doing some detective work could actually really help people, definitely makes a difference to, you know, it's a really nice part of this.
How could a pituitary issue, so someone has a TBI, and we mostly focus here on mild TBI to moderate, but if someone has a TBI and then a pituitary issue reading off that, what sort of symptoms would they see?
That's such a great question. It's I do pay a lot of attention to symptoms. I think they're what should drive the evaluation. The tricky thing is that the symptoms that you can get from pituitary dysfunction overlap so much with other symptoms you can have from a concussion, mild concussion, you know, TBI or moderate TBI. So they can include things like fatigue and brain fog, irregular periods, changes to libido, changes to mood, physical changes such as to weight, quality of life, by which I mean people just don't feel like themselves. It can be hard to describe why, other than that people sometimes say they just don't recognize the way they're processing things. So there are a whole host of potential symptoms you can have. You can have one or two of them, you can have a lot of them. And unless you look, you won't know if some of them might come from a pituitary deficiency.
But how exciting, because there's a yes/no answer based on blood work.
Yes, there's based on the blood work and kind of, actually, yeah, sometimes judgment comes into it because there can be gray zones, but absolutely, if you look, you should be able to find whether or not there's a deficiency. I try to always set things up to say, you can have these symptoms that are likely that come from pituitary deficiencies, if we find a pituitary deficiency, there's a great chance that you can ameliorate the symptoms, but you don't know which of those symptoms come from the pituitary deficiency or other aspects of the concussion until you replace it. So I always like to work within a network of people where if the replacement doesn't fix things all the way, then what do you do? I like to think of the next step so that it's not just a, well, did what we could.
Didn't work. Do
Yeah.
you think, I mean, you can look at John Ortiz study out in Arizona with adolescents. I think it was 65% of adolescents from their ER visits had hormonal disruption. I mean, some of the studies show there's a great possibility of this. Do you ever see that screening for hormonal disruption will be a part of, some point if people are, 6 to 8 weeks out and still having symptoms?
I think so this raises two great questions. One, I think the time to start thinking about probably is almost like 3 months out, just because we don't know how deficiencies, whether the deficiency of their body's way of kind of holding on to its energy for something else, for some of the deficiencies. And secondly, I hope so that there's so many people who have mild concussions that it, if it were easy, if it weren't, if it didn't take resources, both financial and time and other things to do the test, then it would make more sense to screen everybody and try and spend a lot of time. I think people in this field try to spend a lot of time thinking about how can you predict who has deficiencies, because there aren't really any great predictors other than symptoms. That's why I say if you have persistent symptoms, at a certain point after your injury, then you should consider it. At some point, maybe there will be a biomarker that seems to be a good enough marker that you could use that, but right now we have symptoms. So I do think that screening, I'm hopeful that it becomes more a part of things. And I feel almost bad saying, well, not everybody, but that's based entirely on kind of cost effectiveness.
Exactly. And as home testing is coming in, I mean, the testing field is changing so radically with, we'll talk about this in a second about COVID, but just to go back, I do want to check some of the most frustrating symptoms I see in our support groups are POTS-like symptoms where, somebody gets up and they have a sense of the curtains closing or a dizziness or any of those where you're changing vestibular issues. Is there any part of pituitary or hormones that would also have a place of that if someone has like POTS type symptoms that they want to get tested?
That's a great question, because I think the autonomic dysfunction that can be seen after concussions or after COVID, or people who do have POTS, there's always that question, could there be a hormonal component? There sometimes can be. If somebody has adrenal deficiency, which is not that common among the pituitary dysfunctions after a traumatic brain injury or concussion, if they do, it could absolutely lead to that, and then you could potentially fix it with replacing that deficiency. But generally, I think that's usually a separate process. And not always.
I use the term POTS, and I did want to, it's say with POTS, orthotic tachycardia, yeah.
Syndrome, orthostatic, exactly. So it's when you change your position, when you go from like lying down or sitting to standing, you have changes in your heart rate. I guess it's the tachycardia it talks about, or it can also be in your blood pressure that change how you feel. And that's I use the term autonomic. It's a different, it's neurologic. It can be neurologic, but it's not the type you think about. It happens automatically, and so it's potentially an autonomic problem. And so that is not often that can exist separately from pituitary dysfunction.
But I do, like, my son very much suffered from that, and the doctors just kept telling him he was dehydrated. So he literally walked around drinking water all day long, but especially in a high school situation where you're getting up and down and up and down, it was very, very frustrating for him. And I spoke at a conference at the VA, at the Harborside VA, where they had experts on POTS, but literally they got swamped after the meeting, and there's just not enough doctors that specialize in that piece. So I wondered if you were going in with post-concussive symptoms, whether that could be a screener. So that was a little side thing there. So going back to I want to give you a chance to talk about your work now and the different places you're located and the different teams you're working on.
Oh, sure. So I still broadly see patients who have issues with neuroendocrinology or reproductive endocrinology, but a lot of it does have to do with post brain injury of different types, pituitary deficiencies. So somebody who's had a concussion and has persistent symptoms, people who have had COVID and have persistent symptoms, patients who've had POTS or Ehlers-Danlos, and then generally, people who are worried about how things might impact their fertility, and any sorts of questions along that way, apart from concussion or brain injury as well. It's funny, I was had physical locations in New York and the Virginia area, and then when the pandemic hit, I started seeing patients by telemedicine and realized it was an opportunity to provide access or offer access to patients who lived remotely, who I didn't want people to have to travel, so the regulations changed a lot in the pandemic so that you could get limited licenses for the duration of the public health emergency. And if you apply for this limited license, and if your insurance let you see patients in that state, I could talk to patients in, Idaho and Wisconsin, and not just in the places where I was physically located. So it was an interesting education for me to sort of get a sense of the different access people have. It was really nice to be able to see people in different parts of the state. I would still have to find someone for them out there because oftentimes either a physical exam seemed like it would be required as part of it, or testing. So just getting your blood test in the morning can tell you a lot of things, but sometimes you need to do what's called provocative testing, where you try to drive the body to make a hormone and see if it can respond. And that requires going to an office with, a physician or an endocrinologist, someone who can do that testing. And so that also required essentially hooking people up with physicians or care providers in their states.
But I gotta say, what I have found is that if people know what they're looking for, who they're looking for, they're pretty determined to find it, but sometimes they just don't know who to look for. So I do think that these telemed appointments, and I've done them myself with somebody in another state for something, but you now can be more articulate about what you're looking for in your state, where you may not have had that, the direction to go. So I'm very excited about the telemed that's out there, and really hoping that insurance stick with it, and that that the gains that we've had during COVID aren't pulled away afterwards.
Yeah, there's a lot. I mean, I not much can take the place of an in-person meeting and examination, but not everybody can really comfortably go to an exam. So, either making it available when needed, or certainly for follow-up where you can see somebody, you can talk in real time. There's more familiarity now with it, where it doesn't feel so different to do sort of essentially a secure Zoom call to see a patient. I think that really does open things up for people.
I see a couple of questions in the chat room, and that if you have a mild TBI, you have prolonged symptoms, 3 months, you find there's a pituitary issue, you start a replacement hormone. At that point, we have so many different variables, but in general, is that a couple of months on that replacement hormone? Is that a lifetime? What, in a broad sense, everybody's individual, everything's individual, but in general, is it a kickstart? Is it a couple of months, years? What does it look like?
That is a great question. And it's one of the reasons I think it's one of the differences between pituitary deficiencies that you can get from a TBI than pituitary deficiency you can get for other reasons, like having a pituitary tumor. I don't mean cancer, just when you have a collection of extra cells or radiation or surgery. Those tend to be more permanent. However, we know that after TBI, and when I say TBI, I include mild TBI, I include concussions, first of all, they can appear over time. You cannot have a deficiency at 3 months and they show up 12 months later. There have been studies done both in adults and adolescents that follow the same people at, from 3 to 12 months. And some people develop new deficiencies at 12 months. And we think even thereafter. There are people who develop a deficiency and it stays, and there are people who develop a deficiency and it improves. So you can't tell necessarily for an individual, but it is the type of situation where it doesn't mean that you have to stay on something for life necessarily. It's a replacement for as long as you need it. And you can tell when you stop needing it by retesting.
That's really fascinating. And it falls into so many stories that I've heard and experiences from women, especially, I can't tell you how often in our support groups where women come in and there's a disruption in their period, a change in flow that, that they're noticing, but not having any way to correlate it. So, that's really great. That's going to help me a lot with when people come in with new symptoms. I think too often, especially women, are looked at from the psychological lens. Well, it must be, the stress you're under. And, I think too often we miss the physical elements behind what women are feeling. And too often I think we miss the psychological behind what men are feeling.
Yeah, I think that's a great point. In both this and other fields, I'll meet people on occasion who were told that they probably had gone through menopause when testing showed that was not the case. And you can tell that pretty easily by testing. It's quite straightforward. That it was sort of assumed it was that. Similarly, if there's a period stop for a while, become irregular, it can be attributed to stress. Stress can do that. So can stress hormones when they are elevated or dysfunctional or deficient for some reason. And so can other hormone changes and deficiencies. So I think it's really important to look for it and not kind of write it off essentially as something else. And I think the psychological part of it's really particularly important. And maybe that's one of the reasons I like this area, is that I have an interest in that as well. And I think that for both men and women, one, we know that pituitary deficiencies can affect mood and that you can improve the mood when you replace the hormones. Two, your mood will impact your hormones also in a very real way. So while it can sometimes be hard to tell which came first, anyone who has a deficiency it is often recommended to replace them. So
I was at a VA event. I think it was, I can't remember which one. I was at a VA event and they were talking about men and we're talking about moderate to severe TBI. But in general, they were saying that they're 1 year out, because they knew how often that these hormones are changing, that was a standard that 1 year out after a moderate to severe TBI, that they ran an entire hormone panel on men. Do you see that replicated in the civilian world?
In studies, yes, you see it in studies. I don't see it in common clinical practice, but there are studies where it's done also. The interesting thing about the military studies that I'm aware of that have been done is they usually use frozen serum. So it's a single blood draw, and that can be really good at suggesting that somebody might have testosterone deficiency or estrogen deficiency if they're looking at women, or looking for sure for thyroid problems, sometimes for adrenal problems, but for growth hormone deficiency, and that's one of the pituitary hormones. I'm speaking about there's a part of the pituitary I'm speaking about that has these different hormones, the anterior pituitary. So for growth hormone, we know that you can have the screening test that you get on a single blood draw is not growth hormone itself, but IGF-1, which is made by the liver in response to growth hormone. That can be normal in people who, on provocative testing, which is considered to be better testing, who turn out to have growth hormone deficiency. And so, and while that's come to light over the past few decades, those screening tests can miss that, because if you can't do the provocative test, you're going to miss people who have a normal IGF-1, but who would fail growth hormone deficiency testing. So I'm interested to see how, as the testing, you have to look at each study you read, sort of how they do the evaluations.
And what is a provocative testing? Is that what is the provocateur?
Yeah, that's a great question. For growth hormone, I only really use them for adrenal insufficiency, which is a deficiency. In this case, it would be of the pituitary hormone called ACTH that causes the adrenal glands to make cortisol, also called stress hormone. Goes up in times of stress, but also is essential for supporting the body during stress. It supports blood pressure. So if you're looking for a deficiency and you test for cortisol. You look when you expect it to be high. And if it's not high enough to tell you someone doesn't have a deficiency, what we're able to use there for the provocateur, for the stimulation, is recombinant ACTH. So you give what the pituitary would send and you see if the adrenal glands can respond. For growth hormone is itself is made by the pituitary in response to GHRH, which is no longer commercially available in the US. So if you're in the US, the options include ways to drop your blood sugar, because low blood sugar stimulates growth hormone release. So insulin can be used, but we often use glucagon, which is gentler. Takes a little longer, the testing, but it's a gentler way to do it. And there's now an approved oral agent called masomrelin. It's a ghrelin agonist, and that analog, and that also causes the pituitary to reach growth hormone. So that's in adults. In adults, those are the ways we do it. In children, there are different stimulants that are used, and oftentimes other indicators such as height velocity are used, because in kids, height will be affected, whereas in adults you see it in other ways.
Oh, there's so many different directions that I want to go with this now. All right, so it was just simple. I want to simplify for a second. So when you have a TBI, you're 3 or 4 months out, they're not finding the issues that nobody, you're not getting the sense. Do you go to, what kind of doctor do you go to between your internist and seeing someone like you? Would you jump from an internist to go see you, or would you go to a neurologist? What would be the pathway to getting to you?
So if somebody wants to see, so I'll say, first of all, that anyone who is aware of the issue and feels comfortable with ordering and interpreting a test can do it. It can be an internist, it could be a physiatrist, it could be a neurologist. It matters less who the physician is. It often does go to an endocrinologist, or specifically neuroendocrinologist, which is someone who deals with pituitary hormones, to sort of do the more specialized testing and evaluation, but you don't have to do that. And you can go directly to somebody, from your primary care provider. You don't have to go, through a circuitous route. But I also don't want to say that it's, there are neurologists, there are people in physical medicine and rehab, there are other care providers who are aware of this and can either start the evaluation or recommend it.
What about for a woman going through a gynecologist?
Great question. So the gynecologist, if that gynecologist were aware that this happened, that patients who've had a history of concussion can have pituitary deficiencies, can order the test, or they can refer somebody over to a neuroendocrinologist. I think it's as long as somebody's comfortable with it, it doesn't matter. But it's not always so common that it's a specialized area, so not everybody is aware of it. I have patients ask me questions about other things all the time, and while I'm happy to talk to colleagues who do research, there's plenty of, I'm not the expert in it, so I usually recommend that they see someone who sees that all the time, who can maybe recognize something pretty quickly. And
I think that's why in TBI it's so important that people work in teams, and yes, it's not a great business model to have all these team members standing around not sure who's going to work on who when. I mean, I think that's one of the reasons that smaller clinics don't make it, is because you need a range of MD experts, but you don't know for which patient you need which people. And yeah, so I think that you're embedded in great teams right now that allow that ebb and flow.
And just even if you need to form your own network of people, right, to be able to sort of reach out. I miss the days when we were in person in academic medicine and you kind of meet in teams to discuss cases, but those were usually not multidisciplinary teams. They sometimes are. And if you don't have that, you can create your own by reaching out to people. And that's something I frequently do is I'm not going to have all the answers for someone. I'd love to help them if I can, but again, you want to be able to make sure they're getting the help they need, regardless of who provides it.
So really random question. What animals have pituitaries? What other animal research can we look to that to see the next wave of research on this?
I think any mammal in which research is done has a pituitary. So potentially there can be similarities there. So mouse or rat models. I used to do research in the chick. They had a hypothalamus. I would think a pituitary, but I would want to look that up before I did it. But the research that's being done is often done in mammals, and
I'm really big on pig research after Candace Floyd. She got me on the whole pig thing.
So yes, they have pituitaries also.
Okay, good. I was hoping that was my bottom line is, do
Yes.
pigs have it? Because since they have the folds in the brain, Candace has me, looking for every pig research project I can. I mean, it's interesting to read about the mice, but they don't really translate at all.
Yeah, monkeys, pigs, dogs.
I'll stick with
not every animal has the same hormone balance that we have, right? So what's right for a pig is not necessarily right for a human in terms of hormonal balance. But the system, the fact of the feedback loops should work the same way, just equilibrated for a pig and not a human.
And the reason we're talking about this about animals is because too often the papers print with a great, we've solved the problem X in medicine and we can now make, mice rise from the dead, and it doesn't translate to humans at all. And so it's really, when you see research, animal research, we really need to look, and many reasons, a whole other story, but those the larger animals, what between, being able to cure a mouse and having it not translate to a human, what animals can we do research on to try to move what we can do with the rodents towards
further up
treatment with the humans.
Yeah, and interesting. I mean, in this area, there's actually a lot of research and the ability to do research in humans. So, so it would be, you can also do clinical research, human research, and be able to observe directly what happens. For things that are more experimental, they often do start earlier in the mouse or in the chick. And yes, the chicks do have pituitaries also, so that's why we were doing different research, but it was neuroendocrine. But there's the research you talked about in veterans, any research in people translates, but it translates to the group in which it was studied. So if the study group is of men who report sexual side effects, the findings should be reproducible for men who report sexual side effects, but not everybody. So it's important to look at the ingoing criteria and the tests that are done. The question asked about stimulatory tests, about provocative tests, was a good one because different papers use different tests, and that's important to look at too. But mostly to look at the description of the cohort, the study population, is really important because things don't always translate.
If adolescent boys were studied, it's not going to translate to a woman in menopause.
It may not translate, or honestly, if people who had a severe enough injury that they were hospitalized or studied at 1 month, well, that's quite different than either that population at 4 months or a population who had repetitive sports injuries but was never hospitalized at 1 year. Like, very different.
Are there times in a person's life where the pituitary, because it also includes the sex hormones, but does the pituitary in general go through, an adolescent, looks one way in adolescence, another way for a woman during fertility years, and then different postmenopausal?
The hormones do. So it's really important to know what age somebody is, what stage they're in. You can be the same age, be a different stage in puberty or in perimenopause, and the timing vis-a-vis their period if they are having regular periods. So those are all really important to help to interpret the values, because not only do they change over the course of a lifespan, but they change over the course of a month. And in fact, many of these hormones change over the course of a day. They go up and down, which is why a specific time of day is important to measure. Testosterone and cortisol need to be measured at a specific time of day. Estrogen, you can interpret it when you know sort of somebody's phase and also their menstrual cycle phase. So you need to know those things. Growth hormone, IGF-1, is also different in terms of men and women and age.
All right, the future. What are you excited about? What do you want to see in your own field? What do you want to see how it works in correlation with brain injury and other diseases and illnesses out there? Like, what would you what are you excited by, and what would you like to see?
Well, two different areas. One, I'd like to see there be the awareness and education of this that really are needed to drive patients being treated appropriately. By which I mean it's just too often that people come to me and they've said the same thing to 5 people and they have felt dismissed. So that really gets to me. Someone not feeling heard that shouldn't happen. There should be more awareness, even if that physician or care provider doesn't see this, to say, yes, I've heard about this, perhaps you should see, instead of being told, that doesn't happen. Which I hope is happening less and less and will stop happening. In terms of research, I'd love to understand more about sex differences, right? How does not just estrogen itself, but how do different phases, different parts of a cycle affect how people experience their hormonal changes? I think that I hear all the time that people feel different throughout the course of their menstrual cycle. People have had concussion and it's not clear why. I don't think there's been a lot of enough research into that. I personally am particularly interested in how other types of injuries might both have parallel courses to the pituitary dysfunction you can see after traumatic brain injuries, and how learning about that can help us understand why you have the pituitary deficiencies. There's a number of very reasonable theories as to why you have pituitary deficiencies after a concussion, but we don't know what the reason is, or even if there's more than one reason that can happen for different people.
What are some of the theories? Is it physical, that it was that it was actually damaged because where it is in the brain physically, or do they think it's part of the chemical cascade that one thing leads to another? I know that Anne Rasmussen talks about and it's way above my pay grade, but that there's no alloprogesterone that is produced because the progesterone drops after TBI, and there's a complicated chemical reactions, but then in the end you don't have alloprogesterone, and that how a TBI can set you up to be twice as more likely to have PTSD after a TBI because of this lack of alloprogesterone. So is it a chemical cascade, or is it a physical shearing when the TBI occurs?
Well, I should listen to some of your conversations with her, because that would be really interesting to learn about. I should have mentioned that how PTSD can play into this or not is just, I think, also important. So in terms of why you can have pituitary deficiencies or dysfunction after a concussion, the potential schools of thought are, one, that it is physical, either the effect of the injury itself. You can have shear injury. So the pituitary hangs down from a stalk, and it hangs through basically a hole in the bones, and it sits in a bony saddle. So it could get hit any number of ways if the head is shaken. It also, so you can have bruising. You can also, because it hangs from a stalk, that stalk is how it gets its neuronal impulses and its blood flow. So if the stalk is twisted or injured, that could cause some problems. So that's a whole different bucket that includes different ways where the physical injury can make a difference. It might also be that a chronic inflammatory state is set up, and that's what causes some of the dysfunction. That might explain better why you can have deficiencies that show up a year later that you don't see in 3 months, for example. So those are some of the schools of thought. They're all reasonable. We just don't know what the reason is.
In purely looking at the anatomical aspects of pituitary, do they look any different in male and female? Like, is that stalk more narrow in females, or just from literally looking at it from that perspective?
So that's a great question, and I don't know the answer. I know that in women during pregnancy, the pituitary normally expands in size, and then goes back, and that may be because there's some of the cells you get more of them. But I don't know whether the stalk is different in men or women, and I've only really seen it on MRI. Right? There are anatomical studies, like autopsy studies but I don't know I think it's knowable, and maybe if somebody on here knows the answer, please, unmute, and I would love to learn, but I don't know the answer.
Well, and I have been waiting for 10 years for Doug Smith with his
Yeah.
larger crew, but
Yeah.
the nanotubulars looking at, I've literally been waking, growing up in the 70s with, here is a lung on smoking and here's a lung not smoke, like I wanted to have that smoking lung versus non-smoking lung. So the nanotubulars in his work to show both in mice and humans that there are fewer in the nanotubular level in the axons, that they're more slender and fewer in the female. So I didn't know whether that translated, from a pituitary standpoint. And then chemically, the output is different depending, what pituitary does depends on sex of the
Yes,
person.
the output is very different, and between individuals too, but the ranges of what's considered to be a normal range are different between people born women and born female and born male. It's interesting. I just met with Doug Smith last week, so now I'm going to go back and say, oh, guess who just brought you up?
I'm always bragging about his nanotubulars. And then he uses my Yoda meme of concussion, there is no mild or something. And he puts my meme up, and then I'm always talking about his nanotubulars. But sometimes things aren't real to people until you show them a picture.
Yes. Yeah. You mean in terms of the pituitary itself, in terms of showing someone what it looks like, or like
well, just from my standpoint of advocating for sex differences in TBI, literally was, women don't play as hard in sports, they aren't as motivated because they aren't going to be paid as professionals, teenage girls, like just the minutia I've had to wade through. And I'm like, look at the nanotubular, I've been waiting for the picture. So what are you waiting for in your field? What do you want to see happen?
I'd love there to be more understanding about growth hormone deficiency, how it is best measured, because we have these different ways of looking at it. Sort of, will the real growth hormone deficiency please stand up, and how it works in concussion. It may be different. I treat it as though it works the same as it does after a pituitary tumor. Again, not cancer, just extra cells or radiation. But we don't really know. We don't know if the hormones act the same way. So I think that's something that can really change things. And again, then also looking for how evidence of these changes after different types of injury can help us understand the injury after concussion. I think that things can really inform one another. And in addition to sort of thinking it's essential to have multidisciplinary conversations, I think it's important to kind of look at how different things that look similar but come from different reasons, maybe you can learn about them. You can learn about from one to the other. Patients with long hauler syndrome often describe things similarly to patients who have pituitary deficiencies after concussion. For example, patients who have constellation of symptoms that include Ehlers-Danlos and POTS and mast cell issues can describe some similar symptoms. We don't know if there's a similarity there or not.
The long haul is very interesting. I spent last year working in COVID testing and then talking to patients, and the long haul concussive symptoms and long haul COVID, there's so many similarities. And yet, you're having, again, invisible symptoms and trying to prove your point. And I think too often people get isolated from medical providers. So I always, listen to people, believe them, and say, if you find one medical provider that is shutting a door, and just keep trying to find, just keep going back out there. I wish there were more of you out there. I want to open the Q&A up, and I know it's very, if there are any researchers or medical professionals first that have any questions that wanted to unmic, and then we'll then go to patient questions. And with the patient questions, I know it's terribly hard, but we really have to stick to general questions and not specific questions about one's own particular case. So are there any medical professionals out there that have a question? They get to go first this week. Okay, then we can go to any questions from patient advocates in that thing. And Kara, are you reading through? Because I know there are a lot of chats going. I'm not as talented to read and talk at the same time. Jason, you had a question. Welcome, Jason.
Hi, Dr. Wexler. I'm more of a researcher, not a patient, sorry.
Nice
But I just had a question for you. We're looking at cortisol and testosterone too, and I look in the literature a lot, and there's a bit of a split between some people trying to avoid that diurnal variation and collecting in the afternoon and analyzing it there, whereas I'm more in the camp of we should collect in the morning so that we actually see those peaks and troughs, right? So I'm wondering what your opinion is on that and what we should stick to.
No, thank you so much for the question. So are you looking for cortisol deficiency or testosterone deficiency? Yeah, so when I look for deficiencies, I look in the morning. And listen, it can be tricky because other effects of concussion include, for example, difficulties with sleep, and circadian rhythms can be completely altered. So, you know, it is not necessarily perfect, but I think it's the best we have. And I do stick with that. And not just morning, but I'd like to look before 9 a.m. I say 8 a.m., but I'd like to look before 9 a.m. I think sometimes I see tests done like at 10 a.m. and it's hard to know how to interpret that. So for testosterone and cortisol, when I'm looking for a deficiency, I look when you'd expect them to be highest at the way that you do.
Great, thank you.
Yeah.
Nat Dean, your hands up, and then Deborah.
Hi, thank you. This is very fascinating. The POTS, it's not POTTS. I was trying to look under that and I came up with very weird things. That's POTS. And thank you, because this just answered a big question for one of the clients that I'm working with.
Sure, I'm delighted.
And the other question is, lately I have been working with folks who have been told that their thyroid tests were not to be done fasting, and they were typically in the past done fasting. Is there a debate about that, or is this a subject for another conversation? Thank you.
You know, not that I'm aware of. I mean, there are things that I'm not aware of. So, but because I do other things fasting, I often do things on the same blood draw. I do the thyroid, the TSH, and free T4 fasting, and that tends to sort of get rid of changes you can have based on what people have eaten. So, so I don't have a problem with it being done fasting. But if there is information out there suggesting otherwise, I'd certainly be happy to hear it.
Thank you. This has been fascinating. Very, very interesting.
Thank you. You know, what Jason asked reminded me of something else that I think is important to think about, which is, you know, the cortisol reactions. I'm talking about cortisol deficiency. See a lot of patients who seem to have unexpectedly high cortisol levels, and while elevated cortisol levels can come from anxiety, I think that it's possible they can also come from other dysregulations, and that could produce more anxiety or be related to it in a different way. And so I'm hoping that there's more research into that. You know, you even see kind of this high startle reaction or fight or flight feeling in patients who have growth hormone deficiency that anecdotally seems to respond to the replacement. I don't have a reason for that specifically, but I think it's interesting. So your question about cortisol made me think of that.
That's one of my provocateur thoughts, because I'm one of those people that literally, my kids would love to come up, you know, when I'm waiting for them after a carpool situation and like pound on the window and see like if I throw something inside the car. I am a startle response person to the nth degree. So I wondered whether you had people in the lab and you went over and, you know, scared them to see their stress reaction.
Yeah, no, I would not do that, because my kids do the same thing, and I am not so appreciative of it, because but I do think that kind of, there are people who didn't used to feel like that, or who describe having it new since a concussion, who are much more kind of seem to be in a guarded state, like something could happen at any time. And there's a lot to talk about there, and different things that
we're going to have you on again, definitely.
I'd be delighted.
Deborah has her hand up, and I want to make sure you have a hard stop at 3.
No, I left a bit of a buffer if there are other questions.
All right.
And I'm happy to put up an email if there are other questions as well.
Yeah, well, definitely. Let me ask Deborah ask her question, and then I want you to you can restate all your affiliations so that we get all the different places that you are. Deborah.
Catherine, I also see some questions in the chat too that I can read after Deborah.
Okay. You're mute. You've gone mute.
Can you hear me now?
Perfectly. Hi.
Great. Oh, I used to work in the developmental disability field. And so I thought I was an advocate for people that had a developmental disability. And I have a TBI, persistent, I would say. And I just want to thank Katherine for doing this whole pain concussion, but also these trainings or these sessions. I have learned so much in just the last few weeks. My question to Dr. Wexler is, and I think it applies to everyone. It's not real specific, but I did have an endocrinology study, and they did part of it in the morning. And then because there was a mix up in scheduling on their part, it was an accident. The second part had to be done in the afternoon. And my scores qualified for human growth hormone, except 2 scores didn't, and they were both in the afternoon when I had been fasting since night all morning. And then because it had to be in the afternoon and I had to drink a real sugary drink, does that affect your scores? I guess it's my question.
So it depends what test was done. If you're looking for growth hormone deficiency,
yes.
So time of day, when you're doing a provocative test, time of day shouldn't matter because you're using a different stimulant. The test I know with growth hormone, and I'm happy to discuss offline if you would prefer, to drink something sugary is usually to look for growth hormone excess, and to look for growth hormone deficiency, you usually try to drop blood sugar. Now, it may be that there have been different tests done over time, but I'd be happy to speak offline about it too. So it's not so much like if you're doing a fasting test where they gave glucagon and then you had to drink something sugary and then drew it, I would think
that's
that
what
would
happened
obviate
the
it.
second time. Yes.
Yeah, you to look for deficiency, you want to make sure you're trying to drop your blood sugar. So if it was something after you ate and you're looking for deficiency, I think it would invalidate that test unless the macrolide was sugary and it was in the last 2 years when it was out. 1 year.
Sorry, what did that last part I missed? I apologize.
I don't know what I don't know what oral masamorelin is. A powder you put into water to drink. That's a ghrelin analog that you're not trying to drop blood sugar. It's a different way to get growth hormone stimulant. I have not heard that it tastes sugary, but I actually haven't tasted it. So I'm just saying if that was the agent you were given to try to drop your blood sugar, it's possible that it tasted sweet.
No, they were trying to raise my blood sugar because my blood sugar actually had gotten so low they wanted me to drink the sugar.
Okay, got it. Because it was so low. No, that completely makes sense. The growth hormone levels they drew after you drank anything, even if you had drunk just juice or eaten some nuts, don't count towards the test. Okay,
so it shouldn't have invalidated the test then. Because it was funny that my scores raised.
Well, yeah, it's a good question. You look for a threshold below 3 in this case. And if you ever catch one above 3, it suggests, in fact, that somebody's not truly deficient, but it's not actually part of the test. So I think that's open to discussion.
Okay. I loved your presentation. It's like you're the one I wanted to hear, but then I listened to the last 2 weeks and it's like they're just fantastic. So of course I have the eye issue also. So
well, they all work together. So maybe it's
I know
you're the collaborative you have all going on.
Yeah. Yes. Yes.
Tamara, do you want to talk about the collaborative that you have going on?
Thank you so much.
Sure. Oh, no, it's a pleasure. Well, so I'll separately say, so I do have a few places I'm affiliated with or work. I am on faculty at NYU and I used to see patients there, but I now just do research there and see patients through telemedicine or my own kind of clinic. That clinic is affiliated also with the Concussion Care Center of Virginia, where Dr. Zassler and Jackie Thies work, Sarah Etheridge is speaking, and I'm adjunct at Penn, so that's why I was meeting with Doug Smith and Ramon Diaz-Arastia just last week. to talk about research with them, and also have been really honored to join research conversations at UTMB with Brent Meisel and his colleagues. So it's a really nice group of people that work in this area.
Really great group of people. Kara, do you want to read some of the questions? And again, if you have to leave, I'll have the recording up before next week. And I'm just about the processing is done. I'll have last week's up. And I do know sometimes people have to leave at the top of the hour. So thank you. We'll just do a few more questions. But if you have joined us and have to leave, thank you for being here. Over to Kara.
Hi, thank you for a very interesting, valuable presentation. I see one question and then I had a follow-up to it. Could a TBI affect production of female sex hormones permanently? And I think that it's often like long-term, care and monitoring, like how can that be implemented? Because I think when it comes to motivation, moods, neuropsychological and reproductive challenges do not seem to be recognized as caused by brain injury or properly evaluated by hormonal testing. And I think that it's critical, to understand that, whenever you're having issues and different doctors, that you're seeing to address this.
Yeah. So the TBI can affect hormones in a number of different ways. In terms of estrogen itself, it can absolutely cause an impact to the pituitary signals to the ovaries to make estrogen or to ovulate. That can be permanent, that can be temporary by individual. But I think is a broader question is the importance of paying attention to stress, mood, estrogen, ovulation, fertility, how they impact one another, because any one thing will impact another one. And it's kind of a pet peeve of mine when women are told, oh, you're just stressed. They might be stressed. And in fact, in some cases, emotional or physical stress can stop somebody from ovulating. I think of it kind of evolutionarily, like when would your body not think it was a good time to have kids? But that doesn't mean somebody can do anything about that. And I think it's really important, especially in those cases, to offer different ways to help and different ways to try to affect that instead of, telling someone not to feel stressed, does not work, right? Does that ever work to say, oh, just relax? It does not work. And I think it's dismissive.
So why isn't neuroendocrine evaluation a standard part of post-concussion or TBI treatment? Is it because the effect doesn't appear to longer terms, or do you see it as being implemented through the concussion centers or other programs?
I think it's oftentimes, so where is that person at 3 months afterwards? Because while for cortisol, it's important to look in the acute phase, because if you have an adrenal insufficiency, it can be potentially fatal if you can't support your blood pressure. But people with acute deficiencies, it doesn't predict the chronic deficiency at all. You can have acute adrenal dysfunction and you're fine at 3 months. So I tend to focus on 3 months out, and it's also when I see patients. So it's kind of, are the patients still getting to the right medical care at 3 months who would recognize this? I think that it should be part of a standard toolkit for patients who meet criteria, meaning that they have persistent symptoms that sound like they might be related to pituitary deficiencies. You will not know if they have the deficiencies unless you test. And there's an expense to that, but there's more of an expense to, like, I would say there are other costs associated with failing to diagnose and treat something. So I think that it's partly the expense. I think it's partly that it's, the provocative tests can take 2 to 4 hours, 2 to 3 hours, say. And, not especially during COVID, where do you find space to do that? And getting the replacement can be a hassle with the insurance company, but those are not related to the medical need for it. Those are all health system issues. So medically speaking, it would be great if we had a better predictor for who develops pituitary dysfunction so that you knew whom to test. But until we do, I think that symptoms are the best way. And I think people should be screened more often. Am I answering your question, or am I just getting on a soapbox after you asked something that's kind of related?
No, I think you did. I think that it's something that needs to be, integrated. And so it's good to see that, that you think that it will be. I hope so. Another person asked, how can they wean from growth hormone injections from 3-year deficiency from concussion? So I guess, is it possible that it does reactivate the system, or is it that you need long-term?
So that's a really good question. Yeah, so you don't know if somebody has persistent deficiency or if they have recovered. There are indicators in that depending on when you were first diagnosed, if it was, at 6 months, you may have more of a chance of recovering. We only are guessing that based on the length of time at which studies were done. So, studies are only done for a certain length of time. If you were diagnosed at 6 years, maybe there's less of a chance of recovery, but that's again, guessing based on the studies we have. The only way to know if you've recovered, there are some indicators. Are your IGF-1 levels changing? Are you starting to feel the effects of excess growth hormone a little bit more than you used to, sort of the side effects? But generally what is recommended is to stop it. It doesn't mean you have to stop right away. You can talk to whoever's prescribing it about tapering it. You have to be off it for a number of weeks and then repeat the testing. And it's not always such an easy thing to think about stopping something that you're used to. So I think it's worth talking about. But that is the way to determine whether or not you are still growth hormone deficient or not. And if you're not, absolutely you can taper yourself off. But if your body's not going to come back and serve that function for you, then I would venture that you might continue to feel better on the growth hormone. It's always a choice, right? It's only cortisol where a true deficiency can be potentially fatal. There are elevated risks for certain things for being deficient in other hormones, but it's less of an absolute than with cortisol. So if I have a patient who doesn't want to be on something, and they understand what it does to be on it or not be on it, you may choose to taper off of it for your own reasons, and that's reasonable as well.
Okay, just one more question that I'll read from the list is that would you recommend hormone testing prior to a patient starting on SSRIs for prolonged anxiety, depression type symptoms? And I think that often is very fast, like mood stabilizing antidepressants come fast. And do you recommend, the hormone testing should be done prior to that?
That's a great question. If there's time to get a morning blood draw before someone is started on something that will help their mood, it can be helpful in that not all of those medications can increase your prolactin level. I didn't talk about prolactin. It's also secreted by the pituitary. It's suppressed by signals from above. So any interruption to that can make it go up, or it could go down if you lose the cells. Elevated prolactin itself is not bad for you, but it can suppress your sex hormone axis. And so it would be helpful to get a blood draw beforehand. It can be analyzed later or analyzed then. If somebody is already on something they're taking for their mood, for their health, that might raise prolactin, I factor that in, but I do not take them off for that reason. I would never recommend stopping something that someone needs just to get a better read on whether their prolactin is up. If someone needs, let's say they're on a medication, antipsychotic, not suggesting, but those do raise prolactin, which is why I mentioned that. Or they're on an SSRI that does raise their prolactin, and they're doing well on that medication, and the prolactin is elevated and their hormones are down. I just treat the hormones being down because at that moment they need that medicine. If they ever stop it, I would retest, but I don't have people. Wasn't your question, but I often get worried that people think I have to stop my medicine to test, and no.
No, and I absolutely appreciate you underlining that, because what we're doing here is giving general information to people out there for various reasons at various levels. So it's good to know to not stop any medication based on what you've heard here today. So. Right.
It's a very reasonable thing to say. I'm about to start something. I'm not going to get it for the next few days anyway. Should I get something tested beforehand? That's a great question. If you're already on it, that's a completely different discussion. And I also don't mean to suggest that people who are on a replacement hormone just stop it. Like, you wouldn't want to just stop your thyroid hormone. Definitely needs to be discussed to know what to expect or what might happen, because there are health implications. I didn't mean to be too cavalier about that, but.
And not all doctors know all things. I think that sometimes there's frustration with patients that come with an idea, and if you approach a doctor that doesn't have that's not in their lane, go to another lane. I think, and then on the other side, I think too often there, in some cases, doctors don't say that's not my lane. So in the older set, maybe more than I think I see much more willingness, I think, in people newer to the medicine world to say that's not my lane. So
I think it's a real skill to learn and a real strength in saying, I don't know. I'll look it up, but I don't know. And I, you know, if that's important for everybody to say, and it's, you know, I always feel like each person knows themselves the best. You may not know the reason for it, but you know if you're not feeling right. So it's kind of a process of information gathering, and I'm sure it can be exhausting, right? I mean, I always feel really appreciative if someone's going to take the time to come talk to me and go through their story again, and you know, not usually not the first physician they've seen. So that process, I think, must be quite draining.
I think it's also important for people who have survived a traumatic brain injury to disclose that to the doctors, and even if they don't know, because their treatment, you know, may not be effective, or may have, you know, counter, you know, effects to what, you know, was expected, because that information's not out there, you know, and then they can refer you to a specialist as well.
Yeah, and it can be really hard if you're seeing someone and you get the sense that maybe they're not aware of how things can be different in patients with traumatic brain injury. It can be a hard thing to figure out how to say, really appreciate this, but gosh, is there somebody who you think works with patients who have concussions? Because I'd really like to talk to them as well.
And then just people that have a history of head injury and may not correlate. I mean, I think that's or not know about something about themselves. I did want to ask one question. Is there a study found that in mild to moderate TBI, most of the people on the other side with ADHD actually had ADHD before, but they weren't screened for it, and it was coming up after the TBI. Are there precursor aspects, like with vestibular, if you're the type of person who gets motion sickness, car sickness, it can be something that you see after TBI? Are there issues in the pituitary that are enhanced or triggered by a TBI that one would be aware of if you knew you were before, you would look for after?
It's a great question. I mean, if you sort of were teetering on a deficiency, could it push you over? Yes. I don't know that you would know that, or that it, I do think that I wonder, you know, you hear, this is anecdotal, you hear this a lot, that people have different kinds of flare-ups or things that happen after the COVID vaccine. And I think it's that the body's immune response, like that autoimmune response and the inflammatory cascade that can be set off, can kind of go to the weak spots or something. If you posit that it's a chronic neuroinflammatory issue that leads to pituitary dysfunction, you could also surmise that happens. But again, I think it's not known. And I think that even if somebody didn't have any predisposing factors to having pituitary dysfunction or vestibular dysfunction, they can still have it after a concussion. So I wouldn't rule out screening it in people who were completely fine beforehand. The same way that you can have deficiencies in people who have signals on their MRIs, but you can also have it in people whose MRIs look completely fine.
And then a final question on that end. Is there a group that is more vulnerable? I know that John Artez's study looked at adolescent females. Is there a group that is more vulnerable? I mean, research may not have been done, adolescent female versus a postmenopausal female. Is there a timeline that you're more vulnerable than another timeline? Is there a stage in life where you would be more vulnerable to this than another stage in life if you look at the female?
I don't think that head-to-head, like comparative research has been done. There have been separate studies done. So you kind of have to just think about times of life where people might be vulnerable. I mean, I think puberty is a time of life where everything's changing and you don't want to miss something. But so is the perimenopause period. And so is like a time period if somebody is planning to try to have to conceive. But those studies of seeing is there more vulnerability? I couldn't say for sure, because I think most of the studies just look at a set age range.
Oh, there's so much to do. It's so exciting.
I know.
Good question, Nat, and then we'll let Dr. Wexler get back to her day.
Thank you so much. This was amazing. you were talking about vestibular changes, and I don't know if anyone has ever seen this before, but if someone transitions from being a, 5 or 6 foot tall person, then uses a wheelchair for a number of years and then goes back to standing, the vestibular changes in that person because their wheelchair use was because of their TBI, and then they're getting up out of the wheelchair was from recovery from the TBI. And how does vestibular physical therapy assist in addressing their loss of balance, because they've just changed altitude in the majority of time that they spend their life, upright and ambulatory versus seated, which would be a 3 to 4 foot difference in their height. The other thing I wanted to touch on at some point in the future is how do we address the frequency of dementia or Alzheimer's in traumatic brain injury survivors later in their life, because the jury's out on how frequently does that occur or not frequently, because we don't want to put fear into people, but we want to provide the supports of dementia care later in life if necessary and plan for it.
Definitely watch the Willie Stewart episode, because I think Willie Stewart does a really great job on talking about the 12 elements, and your brain injury history is only one of the 12, and basically like 10 other ones in this moment you have control over, which is sleep and nutrition, exercise and stress. But definitely check out the Willie Stewart one.
I'll go back and look at that. I missed it. Thank you. And I'm so glad for you to tell us that the link to review and watch any of these episodes is right there in the chat.
I'm trying to get to 500 subscribers. We have the number of hours, but we need to get to 500. It's really hard. It's a small, you're a small but really loyal group, so I really do appreciate it.
Well, last week couldn't get on because you had more than 100 viewers. So popular is good.
Dr. Wexler, thank you so much for being with us today. And any final words of advice before, and if you want to actually put a comment in the chat to Dr. Wexler, I cut and paste those afterwards and give them to the speakers. So you can use the chat if you'd like to say thank you. But any final wrap up summary you'd like to share?
No, I'd say, well, one, I wish that there was a hormonal component to the development of dementia, because then you could do something about it, but it hasn't been identified. And if you ever have a vestibular person on, I would love to know those answers, but that is one of the areas I don't know. Just didn't want to not answer, but I don't have I'm not the one to ask for that. I'm sorry. I would just say that the questions that everyone's asking, and if you have any questions or if you feel like you're not being heard, it's a lot to ask, to keep asking those questions. So it's a lot for me to ask, but I would ask that because I think it continues to raise awareness and can really help. And I'm very happy to answer other questions. I think, Katherine, you have my email, or Neuroendocrine Associates has a website where there's an email link, and I'm don't want anyone to feel like they didn't get their question answered.
And I'll put I put the link to your website in the comments of the video too. And on any of the emails sent out, if you click through, it will go to your website. So you should be linked. So really appreciate it. And love to have you back again. We'll go.
I love it. I love the Q&A part too. I really appreciate the questions. I really appreciate time. And I really appreciate the work that you've been doing. And, not just in this pandemic season, but throughout the last, decade. So thank you.
Thank you. We got a smart group. We got a really good crew on here. So appreciate everybody having the time to come on, and the link to go to the websites. I want to thank IBIA and NABIS and Margaret, Megan, Jennifer, for everyone helping that makes this show possible. So we'll see you next week for Necker McGregor, and looking at TBI and domestic violence, especially in marginalized communities, women of color and trans. And so that'll be next week. So thank you, everybody. Thank you, Dr. Wexler, and everyone have a safe week.
Thanks for the opportunity. Bye.